Good afternoon, everybody. I'm Kristen Oliver, a pediatrician and preventive medicine physician at Mount Sinai Hospital in New York City. I'm also the HPV Roundtable's designated representative from the American Academy of Pediatrics.
Hello, I'm Rebecca Perkins, a practicing OBGYN and representative of the American College of Obstetricians and Gynecologists. Together, we have the honor of serving as co-chairs for the National HPV Vaccination Roundtable. Welcome.
On behalf of our steering committee, we proudly welcome you to the 2021 National Meeting. This year, we're on a journey to reach new heights of adolescent vaccination rates, and we're thrilled you're joining us. To date, this is the largest meeting we've ever hosted, and while we really miss seeing you all in person, we're so happy to know that we're joined by over 500 HPV disease prevention advocates. As you well know, COVID-19 knocked many disease prevention practices off track, and immunization wasn't spared. Childhood and adolescent immunization is down over 11 million doses in the public sector alone due to pandemic healthcare disruptions. This is more than 20 million doses total. And you don't need to be a pediatrician to know that this is not good news. Our collective mission at this meeting is to get adolescent immunization back on track.
The National HPV Vaccination Roundtable is a coalition of organizations working at the intersection of immunization and cancer control to prevent HPV cancers and work toward the elimination of HPV disease as a public health problem. Our 70+ member organizations represent survivors, researchers, health systems, policymakers, providers, and public health leaders, among others. We have gathered the latest research and evidence for the past 2 years to share with you. Our public meeting objectives are to inform you, explore progress on health equity, activate your organizations. You will be challenged to take resolute action within your home organization to help close the adolescent vaccination gap.
Given the urgency of our public health reality, we're asking you to be fully present today. You may feel like you're floating in deep space, but you're actually part of our rebel fleet, and all rebels believe in a cause. Throughout these 2 days, think about the Roundtable's mission and vision and ask yourself, how can my organization contribute to the elimination of HPV cancers as a public health problem? We're going to keep in touch and we'll be gathering your input through various polls. So pull out your smartphones or open another browser window. We're going to be using Slido. So all you're going to need again is a smartphone or a separate browser window. What you can try and do now to practice is to scan the QR code that you have right there in front of you. You may have to get a little bit closer to the screen to get it to work. There we go. You can also log on through the link using the day one code HPV 6123. Going to do a practice run right now. We're going to start with a word cloud activity. Answer this question. If you could travel to outer space right now, where would you go? The moon seems very popular. Some people are going right to this room on Slido. Fabulous, HPV 6123. I'm glad people want to be right here with us. All right, Pluto, excellent. The moon, of course. Absolutely.
I like the North Star.
I will see you there. All right, so make sure to keep your phones handy throughout the next 2 days so you can be a part of this conversation. You can also see all of the responses right on your screen in addition to seeing it live through the paddle with us. If you want to ask any questions during the next 2 days to us or the speakers, you can use the Zoom Q&A. All right, Rebecca, what else do we have on our flight checklist?
Well, before we kick off in earnest, there are a few pre-flight checks we need to make. All the meeting materials are posted on the meeting webpage, seen here. This includes the agenda and speaker bios. Presentations shared by speakers will be posted after the event. We're recording the sessions and they will also be posted to our YouTube channel after the meeting, so you can watch them again and again if you want to. You can follow our channel by going to HPV Roundtable TV on YouTube. And for all you social media rebels, please tag your posts with our meeting hashtag HPVRT21. And we always love to see the hashtag 2 shots to stop cancer.
The theme of our meeting is reaching new heights. And we've borrowed the imagery of the NASA Space Shuttle program to visually inspire us to shoot for the stars, in case you haven't noticed. Or as we like to say, to immunity and beyond. Our mission would not be possible without the funding and technical support provided by several key organizations. A big thank you to the CDC's Immunization Services Division, who's provided 5 years of funding to the HPV Roundtable, The American Cancer Society is the managing partner and directs our mission and coalition. In addition, the Office of Infectious Disease and HIV Policy has helped fund and advance our work with integrated delivery systems. Thanks to their support, we can defy gravity with the tools and expertise we have right now.
Our mission is critical. As a practicing gynecologist, I see firsthand how devastating HPV diseases can be. People's lives, their futures free from HPV-related cancers, depends on how we meet this critical movement in our nation's public health. HPV infection can lead to 6 different kinds of cancers, as well as a rare disease called recurrent respiratory papillomatosis. Our HPV cancer survivors have always been among our most passionate advocates. They've made life-changing journeys and returned to share their insights and call us to act. The Head and Neck Cancer Alliance is an important member of the HPV Roundtable. They have an ambassador program to help spread the message of cancer prevention. Gail Jackson is one such ambassador. She's a psychotherapist and survivor of HPV-attributed tonsil cancer. She's joining us today to tell us her story now. Welcome, Gail.
My name is Gail Jackson, and I currently live in Rehoboth Beach, Delaware. So I want to talk a little bit about my cancer journey. And that journey started for me in February of 2018. I have a history of sore throats and strep throat, and I had a sore throat that just continued to nag at me. So I went to my primary care physician, and they treated me with an antibiotic for strep throat. And I went off with that medication, but I noticed that within 2 weeks or so, it still was sore and still bothering me. It almost had a feeling like there was glass in my throat. So I went back to the doctor, and at that point, the next physician I saw thought that there was something that looked a little suspicious because I had a growth in my mouth that was actually on my tonsil. So they sent me off to an ENT, a local ENT, and the ENT did a biopsy of the growth, and the pathology came back as a positive HPV cancer-related tonsil cancer. So being in this part of Delaware, the ENT was very upfront and said that this was not his forte. So he suggested I go to either Jefferson or University of Pennsylvania. So we chose University of Pennsylvania, and that started the real work that needed to be done. So in March of 2018, I had a 12-hour surgery that involved removing 42 lymph nodes. And fortunately, they all came back negative. So that was a plus. And in addition to removal in the neck dissection, I had to have a skin graft, which created a flap. So they took the skin from my left arm and put that in my mouth. So I say to people now, my arm is in my mouth. So they did that to cover up the hole that was there. So after I healed from the neck dissection, I ended up having 30 rounds of proton radiation. Now, for some folks, they may choose not to do the radiation, but my family and I, we talked about it, and the numbers seemed to be greater for ongoing recovery and staying, cancer-free with the surgery and the addition of the radiation. For me, I've always tried to stay positive and hopeful because I believe that that makes a big difference in this whole journey. So I think that family members, children, people, whoever are eligible for the shot should consider it as an option, because I really would not want to see anybody go through the journey that I've gone through if it's preventable. And so I think education and doing the research to learn more about how to take care of yourself is a wonderful process, as opposed to not taking advantage of those possibilities.
Thank you to Gail for taking the time to share your story and your time with us, and also coordinating with our color scheme as well, which we fully appreciate here. Unfortunately, Gail's story is not alone. Her story really personifies the disease impacts of HPV. We're going to do a quick level set on HPV disease. There are nearly 36,000 people diagnosed with HPV cancers each year in the US. Millions of women have to follow up on cervical abnormalities, and 300,000 require invasive procedures to address high-grade cervical dysplasia. Over 355,000 people are diagnosed with genital warts every year. And as a mentor of mine used to say, genital warts, no big deal, unless they're your own. HPV's impacts on population health are significant. The CDC has estimated that we can prevent over 33,000 cases of cancer each year with the HPV vaccine. Here, you can see how different HPV types cause different cancer types. HPV 16 and 18, shown in the darker blue, are the most prevalent HPV types, causing the most number of cancers. And oral pharyngeal cancer is now the most prevalent cancer, surpassing cervical cancer.
We have been making steady, slow, but steady progress in increasing HPV vaccination rates, shown here in purple. However, HPV vaccination up-to-date rates, meaning getting both doses or 3 doses if you start after 15, but being fully vaccinated and protected, those rates lag significantly behind other HPV vaccination rates. This is a little bit frustrating as the HPV vaccine was introduced 15 years ago. We know we can do better. While rates are better for initiation or getting the first dose, we still have a lot of ground to be gained. Now we face new challenges from the pandemic, which threaten to undo our progress unless we take immediate action. Let's see what you think the impact has been on HPV vaccination with our first poll. Make your best estimate of how HPV public vaccine orders have decreased due to the pandemic. Do you think vaccine for children orders have decreased 5%, 10%, 18%, or 25%? So we'll give you guys a minute to pull out your Slido again and vote for what you think would be the correct answer.
And remember, you don't have to scan the QR code each time if you just keep it up on your window in your phone. Otherwise, use the link in the chat box.
Those voting numbers are still going up, so we'll give it a couple more minutes to let people get used to the format. Great, and it looks like the most popular answer is 25%, followed by 18%. And the correct response is actually 18%. And you'll learn more about this and the deficits we see in our featured presentation.
Thanks, Rebecca. First, we want to position our thinking around adolescent population health. We're honored to welcome Dr. David Bell. Dr. Bell is the new president of the Society of Adolescent Health and Medicine and a valued member of the HPV Roundtable. Since 1999, Dr. Bell has been the medical director of the Young Men's Clinic, delivering primary care to adolescent and young adult males and advocating for the right of young men to have access to high quality and respectful services. Welcome, Dr. Bell.
I'm Dr. David Bell, Professor of Pediatrics and Population and Family Health at Columbia University Irving Medical Center in New York City, and President of the Society of Adolescent Health and Medicine. I am honored to provide the opening remarks to the HPV Roundtable event today. As the President of the Society of Adolescent Health and Medicine, I want to declare from my mountaintop that the health of our adolescents matters greatly. In short, a healthy, healthier adolescent population can forecast a healthier adult population. We have made great strides in our population health overall through prevention, particularly through the use of vaccines. In the context of the HPV vaccine, it means a future adult population free of a set of cancers. What a truly unbelievable year we have all experienced. Although the story of the pandemic has yet to be finished, our lives and the lives of our adolescents and young adults were disrupted in so many ways, including healthcare services. For sure, the pandemic accelerated changes in healthcare delivery through the urgent and widespread integration of and reimbursement of telehealth services. Telehealth now offers the potential for increased access to healthcare services. However, during the pandemic, routine adolescent visits suffered. And as a result, vaccine delivery suffered, except for those in their early years of life. 2020 also highlighted many disparities with healthcare access, only being one of many. Two of the articles that were suggested readings discussed racial and ethnic disparities related to HPV vaccination. One article by Spencer, Kalo, and Brewer had a brilliant discussion on the probable drivers of vaccination patterns. The understanding and synthesis of the literature to date by the authors is that the vaccination patterns are likely a result of systematic differences in care and unlikely related to patient preferences. Location of care, that is, care from safety net providers versus private offices, possibly plays a significant role. Provider level factors, including implicit bias and communication around the vaccine, also are probable contributing factors. The implicit bias in communication by providers was highlighted also in the article by Vu et al. When understanding the HPV vaccine delivery among the diversity within the Asian American population in the US. To further discuss adolescent vaccination, I would like to transition to today's featured presentation showcasing the dual rocket boosters of adolescent vaccination. Speaking from the public health perspective, I'm pleased to introduce Dr. Melinda Wharton, Director of CDC's Immunization Services Division. Dr. Wharton has served at the CDC for over 35 years in a variety of leadership roles. She'll be providing us with context on the pandemic's impacts on childhood immunization with specific requests for action from stakeholders. Dr. Wharton will be followed by Dr. Stanley Spinner, the Chief Medical Officer and Vice President of Texas Children's Pediatrics. Dr. Spinner will speak from the perspective of the private sector and share lessons from his health system as they adapted HPV vaccination practices to the challenges of COVID-19. After their respective remarks, we'll have a group conversation and take audience questions in the question and answer box. With that, welcome Dr. Wharton.
Good afternoon. The COVID pandemic has resulted in changes in all of our lives in so many ways. One of the changes that I know that I hadn't anticipated when the pandemic started was the impact it had on childhood vaccination. But before we get into that, I do want to just start with an expression of appreciation for all of the work done by so many frontline healthcare workers and public health workers in the United States to help us bring this pandemic towards control. This is the data from CDC's COVID tracker, and it shows the dramatic reduction that we've seen in the United States, really due primarily to the vaccination program, but also all of the other mitigation steps and testing that has been done since the beginning of the pandemic. So for those of you who have helped support this, thank you so much for all you've done. It's been an incredible experience this last year or so, and thank you for your work to help bring this towards an end. Now, one of the things that happened early on was a dramatic reduction in people seeking medical care in the ambulatory setting for things other than COVID. This headline is from the New York Times back in May 2020, and the quote is from a pediatrician in Chicago who said, "Our waiting rooms are like ghost towns. There's just no one there." And because no one was coming in for ambulatory care visits, kids weren't getting vaccines. Now, the healthcare providers who take care of children are resourceful. And so they did do things like have well child visits in parking lots, do drive-through vaccination. They did all kinds of things. But the fact of the matter remained that there was a big gap in well child visits, especially early on in the pandemic, March, April, May, that had a big impact on delivery of childhood immunization services. We saw that in our national vaccine ordering data. These are data from CDC's ordering systems, which show the reduction in routine pediatric vaccine orders last year when the pandemic started with following the national emergency declaration in March. And the solid line shows the reduction in vaccine orders cumulatively for 2020 compared to a 2019 baseline. And so you can see it was pretty steady and not increasing up until mid-March, when there was this dramatic drop off in orders, resulting in this much larger deficit in vaccines for 2020 compared to 2019. The dotted line shows the cumulative deficit for measles vaccine as a subset of the overall deficit in orders. Now, the good news is, since the spring of last year, there has been a rebound in weekly provider orders. This graph shows orders by week, with the weekly orders for 2020 and 2021 in the orange color, and the comparison week from 2019 in blue. So each set of bars represents a single calendar week. And what you can see is on the far right side of the graph, things are pretty similar for 2021 compared to the comparison period in 2019. So it definitely looks like things have gotten better. But if we return to that cumulative curve, what we can see is that we are still deeply in the hole in terms of overall doses ordered. As of May 30th, overall VFC provider orders other than influenza vaccine are down by more than 11 million doses. And of that, about 1.5 million doses are measles-containing vaccine, either measles, mumps, rubella, or measles, mumps, rubella, varicella. And this is really, really concerning. There are other data we've seen that show a slower recovery in the public sector compared with the private sector. There also were differences in the gap by vaccine. And if we look at vaccines with fewer doses in the series given to younger kids, the percent reduction is less than in the vaccines with more doses in the series and that are given to older kids. So for rotavirus vaccine, which is given to the youngest infants, only down by about 5%, PCV 13, 4-dose series, the last dose in the second year of life, down by almost 8%. DTaP containing vaccines, a 5-dose series with the last dose at school entry, down by almost 9%. Compare that with the 3 vaccines recommended for routine use at 11 to 12, well up into double digits, with meningococcal conjugate vaccine down by 14%, Tdap down by almost 18%, and HPV vaccine down by 18%. Measles containing vaccines are also down by almost 19%. I will say that because there was a measles outbreak in the comparison period, this gap may be exaggerated a little, but the number of additional doses given in the baseline period in 2019 isn't sufficient to account for this large reduction. So the need for catch-up vaccination is urgent as we plan for safe return to in-person school. We know that many school-age children missed recommended vaccines over the last year due to the disruptions associated with COVID-19. We're especially concerned about the gaps for measles vaccine, as well as the vaccines routinely recommended at 11 to 12 years of age, including HPV vaccine. With everything that was going on last year, schools may have not focused on compliance with school vaccination requirements during the 2021 school year. We do need to get children caught up on vaccine doses they missed so that they can safely return to in-person learning, and there is urgency about doing this. We know that back to school vaccination traditionally happens in the summer, and we need to get kids caught up now. Now that COVID-19 vaccine is available for younger adolescents, of course, that's wonderful. It's great that we now have this vaccine to help them safely get back to in-person activities, school sports, extracurricular activities, and so forth. But we still need to assure that catch-up efforts continue for the routine vaccine doses that were missed. There's more good news in that we actually know what needs to be done. We just need to do it. Healthcare systems and healthcare providers can take specific actions that will help families know they missed doses and come back in and get caught up. And those specific actions, including identifying families whose children missed doses, contacting them to schedule appointments, providing prompts to clinicians who are seeing children to deliver the vaccines that are due or overdue if they come in for something other than a well-child visit, and letting families know what precautions are in place for safe delivery of in-person services, because even now some families may have concerns that coming into a healthcare setting is not safe because of COVID. And healthcare provider organizations can encourage their members to identify and follow up with families whose children have missed doses to get appointments scheduled. Schools and state and local governments can send reminders to families about school immunization requirements. School immunization requirements are a powerful behavioral nudge for parents to do something that they probably meant to do anyway, which is make sure their children are up to date on routine vaccines. So remind them about it. Don't let them wait till the last minute. Follow up with families of children who are not in compliance with requirements to encourage compliance. It's not that we want children excluded from school. We want them to be on their way to getting caught up and then to get caught up in a timely way. Most states' immunization information systems can do reminder recall, and for states that can, that system and that process can be powerful to notify families whose children have fallen behind on vaccines. And of course, we all should communicate directly to families the importance of well-child visits and getting caught up on any recommended vaccines that were missed. We have an opportunity now, as the COVID vaccine program is rolling out for adolescents, to make sure we include routine vaccination in our communication with families and in our encouragement with the public. It's too important to make sure our kids are protected, and we need to make sure that we get routine vaccines caught up on. Thank you.
Hello, everyone. My name is Stan Spinner, and I'm from Texas Children's Pediatrics and Texas Children's Urgent Care. And I'm very excited to be here today to talk with you about the journey that Texas Children's Pediatrics has had in improving our HPV vaccination rates. I am Chief Medical Officer and Vice President of Texas Children's Pediatrics and Texas Children's Urgent Care. Just briefly to tell you a little bit about Texas Children's Pediatrics. We were established back in 1995. Initially, the hospital system purchased several existing practices and then added new practices as well. We've rapidly grown and today are the largest pediatric primary care organization in the United States, employing over 300 pediatricians with 61 primary care locations. 50 of those locations are in the greater Houston area, with 11 locations in Austin, and with plans on expanding to a few more sites in Austin as well. We also have 12 urgent care sites. We have 11 in the Houston area, 8 are in the community, 3 are situated on our 3 Texas Children's Hospital campuses in Houston. We also have 1 location in Austin. So let's talk about HPV vaccine. And the first thing I wanted to discuss is why was the original plan to introduce HPV vaccine starting at age 11? Why not at an older age? Well, we were able to determine and understand very early on that there is an improved immune response for our younger adolescents when they're vaccinated rather than waiting until they're older. And also, if you complete the series prior to age 15, only 2 doses of the vaccine are necessary versus 3 doses if you complete the series after age 15. We also know that our younger adolescents have very long-lasting protection from the vaccine. And we also want to be sure that our adolescents are protected with the full completion of the series prior to any sexual activity. So as we started to look at completion rates, and the completion rate at age 13 has been kind of a national metric. It's a HEDIS measure. As we looked at that, we saw that we are just, not being very successful at getting those completion rates where they need to be. And I don't think that's unique for us. I think that's a national challenge. So we had looked at our overall Texas Children's Pediatrics visit rates for adolescents coming in for well checks. And this data is from a few years ago, but it's still very much the same today. And we could see, as you can look at the slide here, a very sharp decline in visits really after age 12. And I think that's one of the reasons why HEDIS uses that completion rate by 13 as a metric, because we know that as our adolescents get older, they generally just don't come back to their pediatricians anymore. By and large, most of them are healthy, and so they just, their families don't see a need for them to come in to see the doctor unless they're sick. So that's a real one of the major reasons why there's been a challenge in getting our patients completed. They come in at age 11 in the state of Texas. It's a requirement for school to have the Tdap, the tetanus, diphtheria, pertussis vaccine, and the meningococcal vaccine given. So they're coming in at the 11-year-old visit and mostly at the 12-year-old visit. But again, after that, the visit rates really drop off. And we know that a lot of our patients really are not fully protected once they're potentially exposed to HPV because of that. So about 2.5 years ago, I started thinking, what can we do to improve not only our initiation, but more importantly, our completion rate by age 13? And I realized that, the ACIP and the AAP do recommend starting HPV at age 11 to 12, but you can start it as early as age 9. And when we started looking at data from, our completion rates by age of giving that first dose, you can see that the completion rate, if you started at age 9 or 10, is extremely high. And even starting it at age 11, it really starts to drop off at 12 and really starts to decline beyond that. So again, started to think, why are we waiting till age 11 to recommend this vaccine when we can do it, much sooner? And so, even though the official recommendation is to start HPV at age 11, the ACIP and the American Academy of Pediatrics do have as an option to start the vaccination as early as age 9. And I think one of the primary reasons why the initial recommendation was to start at age 11, it was because it was being bundled along with the Tdap and the meningococcal vaccine. So all 3 vaccines would be recommended and given at the same time. But I think we found that a lot of families really prefer not having to give their kiddos that many shots at one time. So separating it out to less shots in a particular visit actually was a helpful thing. We also know that for our organization, we got about 125,000 patients through age 19 that have only received 1 dose of HPV vaccine. We don't know the efficacy of 1 dose. We do know the efficacy of the 2-dose completed series is extremely high, but we really don't know how efficacious just giving 1 dose is. But clearly there is an issue with that. And the other thing about starting it, at least introducing the concept of giving the vaccine at age 9, is it gives us more time to get that vaccine completed. So even if we don't give the dose at age 9, if we at least have that conversation with the parent, then they could read about it and talk with their spouse if that's the case. And then when they come back for their 10-year-old checkup, they can start the vaccine then. And even in a worst case scenario, at least be ready to start at age 11. Whereas if you only talk about it at age 11, often they're not ready to start it at age 11. So, and we found that the families that said yes at age 11 said yes at age 9 and said yes at age 10. So it really made sense to go ahead and introduce the concept starting at an earlier time. Again, increasing the opportunities to get the first and the second dose in. And another advantage that we found is that if we give that first dose at age 9, we don't necessarily have to bring them back 6 months later for a nurse visit to give the second dose. They could just get it when they come in at their 10-year-old visit, which for the most part they're still doing, or even the 11-year-old visit, which they're definitely doing because of the state requirements. So it alleviates the need for that, for family taking time away from work or taking the child out of school to drive in the traffic that we have in Houston and Austin and come and do a nurse visit just for that second dose. It's done when they're going to be there for their next routine checkup. So what did we do to kind of really build this into the system? So, Texas Children's Pediatrics is part of a system. We have, our primary care practices. We have ambulatory at the hospital. We also have Texas Children's Health Plan, which also sees patients. And then we also have an OB-GYN, part of Texas Children's Hospital now is an OB-GYN hospital. So we see adolescent girls in the GYN clinic. So I went to all of our leaders and I said, I want this to be at a system level, not just for Texas Children's Pediatrics. And everyone bought into that. We've been able to use our electronic medical record, which we use Epic. There's something called Forecaster, where our clinical staff, when patients come into the office, can just click into Forecaster and it will show what vaccines are due based on the ACIP. We've modified Forecaster to show that HPV vaccine will be due starting at age 9. So our clinical staff can actually see that if a 9 or 10-year-old comes into the office, if they haven't started, that they are due to start or to complete the HPV vaccine. We also modified our will child template so that it's a default now to actually give the vaccine at age 9. So our physicians, rather than having to, manually order things, a lot of it is kind of done and they have to then opt out. So of course, if the family declines the vaccine at 9 or 10 or at any time, or if the physician decides that they don't want to give the vaccine, they can just uncheck the box. But it makes it a lot easier for them to not only remember it, but to actually have it done for them by having that built right into our well child template. We've also used a lot of evidence-based strategies to really help to get our families to know to come for the vaccine. We've had for some time automated reminder phone calls that we've used to remind families that their child is due a checkup. If they're a month past their due date, they would get a second call to let them know that they have missed and it's time for them to schedule that visit. We also do that for vaccinations. We've largely moved away now from phone calls, and we're doing it by using text messaging, which is much more efficient, and they can actually go directly into their MyChart and schedule that online. So again, it's really helpful for families to get that text message reminding them that their child is due for a well check, or indeed their child is due for a vaccine, and go ahead and schedule that. We've largely done away with, again, as I mentioned, the phone calls, routine emails and letters and cards, kind of an old-fashioned way of doing it that we've stopped doing as well. We really use our MyChart portal to text messaging for these reminders. Another major component that we've done is we use standing delegated orders. And standing delegated orders are orders that are put together, and there's a legal process for this, so that orders can be there for our staff can act on without the physician having to actually manually put the order in. Our physicians have to agree to do these orders, and it's kind of an all or none for any given practice, so that whether it's vaccines or maybe certain labs, things like that, if the patient meets the right conditions for that, the nurse can go ahead or the MA can go ahead and initiate the vaccine even before the physician comes into the room. I think this is a huge advantage when families are roomed and there's a period of time when they're waiting for the physician to come in. The MA can let the family know that the child is due the HPV vaccine and certainly any other vaccine. And if the family says yes, go ahead and just give the vaccine before the physician comes in. I know when I was in my practice, to walk in a room and an adolescent had already been given their vaccinations, it was a whole different world of that child's no longer worried, that child's no longer anxious. They know that they've been poked and the worst part of it's over. So it's a win-win situation being able to get those vaccines given ahead of time. And a lot of our MAs can give their own personal stories that, my child's had the vaccine, my child's had HPV. It was, it's the best thing that we've done to protect them from cancer. And again, starting it at age 9 has really allowed us to kind of take the whole sexual activity conversation out of this. It is a cancer prevention vaccine, and that's what we have focused on with our staff, with our physicians, so that it really has, I think, made it a lot easier conversation to have with our families. So with the different changes that we've done, both with the reminders and certainly by initiating the vaccine as early as age 9, between 2019 and 2020, our HPV vaccination initiation rates increased from 20.8% to 29.7%. Our completion rate increased from 29.9% up to 33.6%. Now, these numbers are on the lower end because we're talking about all of our patients. If we talk about just patients that have been in, our completion rates are over 50%. But these are the rates that we've looked at as comparison. And again, we're very excited about the fact that we have really seen some significant improvement during this time based on these changes that we initiated. And before I complete my talk, I just want to mention one thing about COVID, because I guess today nothing is complete without talking about COVID for the last 15 months. So when we really started shutting down last year back in March, the Academy of Pediatrics had recommended that we really only limit visits to well checks from birth to age 2. I felt it was more important to bring kids in through age 4. So we were seeing, children up to age 4. We were really educating our families about the fact that we were trying to, we were remaining, socially distant. We had no one in our waiting rooms. Families were being immediately roomed. So we were, keeping our immunization rates quite up to where we were before the pandemic started through our, with our younger kids. We're very excited about that. We also, after a short period of time, launched what we call car-side immunization. So a lot of our practices, we had parking lots that would allow us to be able to have the family come and park in their, stay in their car, and we would come down and vaccinate them through the open window. And we were vaccinating our younger kids, we were vaccinating our adolescents. So by doing that in a robust way, even though we couldn't bring our adolescents in through the early part of the pandemic into the office, we were able to vaccinate them in their cars. And again, we were able to maintain a very consistent rate of adolescent vaccine, probably not quite the same as the younger age group, but still very consistent. So we did not see that much of a diminution of our adolescent vaccination rates during this past year. We added flu vaccines in during, when flu season started. And of course, over the last few months, as our PPE supplies have grown and our understanding of the spread of disease has evolved, we've started bringing all of our patients back into the office. Our volumes are almost back up to where they were pre-pandemic, but certainly we're bringing in our adolescents into the office. But even the few that still don't want to come in, we are still doing our car-side vaccination. So that's still an option, and will probably remain an option for some time for families for any of their vaccines. So again, this concludes my presentation, and I'll be happy to take any comments or questions. So thank you very much.
Hi, welcome. Welcome to the live component of our question and answer section. Before we get started with a few questions that we have in the Q&A, I'd like to sort of call attention to Marla Dalton, who has put some information about the National Foundation for Infectious Disease and their free resources, and a point to sign on to support the goals of the foundation around Up the Rates, which is a campaign focused on reaching populations most at risk of delayed vaccinations. So great. Welcome, Dr. Wharton and Dr. Spinner. Great presentations. I'm honored to be moderating this panel. I think starting off, I would like to ask a question that has been raised. And the first is Dr. Spinner, and probably Dr. Wharton as well. Are vaccinations at age 9 covered by insurance?
Yes, the vaccinations for HPV are covered at age 9 by insurance, and of course, our VSC vaccines we are able to give starting at age 9 as well.
Great. And the other question is for both of you as well. Are physicians and clinicians able to co-administer vaccines with the COVID vaccine for adolescents?
I can take that one. The COVID vaccine, the COVID vaccines that we use in the United States are currently being used under an emergency use authorization. And the initial recommendations were that the vaccines not be given at the same time or within 2 weeks of other vaccines. And I think that really was out of an abundance of caution, given that the vaccines were being used under emergency use. Now we have so much more experience with the vaccines that that the recommendations now changed from CDC, and with the recommendation for use of the Pfizer vaccine down to age 12, CDC's clinical guidance does include allowing simultaneous vaccination of the simultaneous administration of the COVID vaccine with other recommended vaccines or close sequential vaccination. The previous recommendations were not to give other vaccines within 2 weeks, and that's not in the current recommendations anymore either. I will say that the EUA did not ever forbid concurrent vaccination. It really was just a recommendation to be cautious so that we had a clear picture of the safety of the products when we first started using them. So a long answer, yes, it's allowed.
That's great. Thank you, Dr. Wharton. The one question for probably both of you as well. I'm not sure what RRPF stands for, but a question came that this organization or this group sees too many vaccines at one time as a major concern in their community on sibling HPV compliance. And I'd like to ask you to speak to that.
So, as I had mentioned briefly in my presentation, we've often encountered families, parents who were concerned about giving their children at any age multiple injections. They thought it was overdoing it to their immune system or whatever the case might be. And we've certainly educated them as to why that's not the case. But nonetheless, we found that when we started offering HPV at age 9, and it wasn't something that I was really even thinking about at the time, but we got a lot of positive feedback from many of our parents that they appreciated the fact that their child could get one shot then and not have to get 3 then at age 11. And so that seemed to be an unintended advantage in that regard by separating them. Others would rather just get it all over with at once. Again, that's the way many people, that's what I would think, but it was an unintended positive finding by introducing it at that younger age.
Great, thank you for that. So just to sort of update the attendees, that RRPF is the Recurrent Respiratory Papillomatosis Foundation. So the other question that has been asked is, this is probably one for both of you as well, is what do you think healthcare providers seeing children and adolescents should focus on this summer to get vaccinations back on track?
Well, I'll start. It seems like it's a really good opportunity as families are thinking about kids going back to school, back to sports, back to all of the activities that we hope people will be able to undertake in a more normal way in the fall, that we're able to get kids caught up on their routine vaccinations, as well as the other important things that happen during well child visits. We did a survey of pediatricians and family physicians October through December of last year about why they thought families had fallen behind on vaccines and were not coming in for well child visits. And one of the big things was not having sports physicals. So as families start looking forward to fall, I think doing that outreach to get kids in for well child visits that are overdue or that are either due or overdue, and making sure that all the recommended vaccines are available and offered.
And just to add to it very quickly, as a pediatrician, July and August for us is like Christmas. December is for retailers. If you don't get them in then forget it, it's over. And we really, every year, really do a very concerted effort to reach out to our families to be sure that they're coming in for their school physicals as early as possible, because if not, they all wait till the last week, and it's impossible. And again, sports physicals are an important part of that. So yeah, we really want to bring them in, and even if we don't see them for the well checks, if they need vaccines, we'll still vaccinate them. And a lot of our docs are kind of resistant to that. They say, you got to get your checkup before we give you your vaccinations. No, we're going to give you your vaccinations either way. We want you to get your checkup. We're going to encourage it, but we're not going to not give you the shot in the arm is important regardless. And so we really focus heavily on that.
Great, thank you for those answers. We have a number of other questions, but I want to start with a question by Elizabeth Hennessy. How do you handle using the patient portal message with minor consent and keep minors' confidentiality if a parent doesn't want the child to get the vaccine, but the minor wants the vaccine? And I think from a confidentiality standpoint, that might go to both of you as well, but sort of the minor consent and the system standpoint might go to Dr. Spinner.
Yeah, that's a tricky one. I can tell you, we talked quite a bit initially about MyChart availability to the parent for our adolescents, because initially we made very little information in MyChart available to the parents, and discovered that for the most part MyChart wasn't being used. And we debated at the hospital even that parents can always get the information if they want it. So we pretty much opened up MyChart to our parents. If the adolescent does not want that, they can then ask us, and we will then take that away and just basically give the very basic information to the parent. We also do feel that as an adolescent, they should be able to assent to getting the vaccine. But again, if a parent wants it and the child doesn't, we leave that to the two, for the parent and the child to determine what they want to do. The real issue for us is when a teenager wants it and the parent says no. That's very challenging. But if the child is living with the parent, we usually will go with what the parent wants, because they are the legal guardians. But MyChart, we're giving that information to the parents, and they discuss that with their with their children, whether they're age 9, 10, or 11, and they're making that decision.
Yeah, these issues about the age at which adolescents can consent to medical procedures is really determined by state law, and there's a lot of variation among states in terms of what's allowed and what's required. These issues have come up around COVID vaccination, with vaccination now being recommended down to age 12, and so we recommend that providers follow the same guidelines that they do for other medical procedures and vaccines for adolescents.
Great. Now, I'll add to that I know that New York state law, we are, by the confidential services, we are able to provide the HPV vaccine at this point in time. And so, as you see, I'm in my clinical office, so this is where we do our work. 2 questions, or at least a follow-up. Do any clinicians have an issue with offering HPV vaccinations starting at age 9?
Yes, they do. Unfortunately, I continue to have conversations with them. I always have asked them why, and they really don't have a good answer. They just aren't comfortable. They're just not ready to make that change. Some of them will say it's the parents, and it may be, but in many cases it's the physician. And, we sometimes are slow to change about what we're used to doing. So it's an ongoing conversation. And I think as time goes on, more of those physicians will develop that level of comfort. Hopefully the parents will be asking for it as they learn more about the opportunity.
Great. One question for both, but more likely more for Dr. Wharton. Why are pharmacies unable to vaccinate for HPV? With so many adolescents getting the COVID vaccine, it would be a way to open the door to parents.
Well, so this is another area where what really historically has determined it is the scope of practice rules in individual states, which are vary by state. Some states are very permissive regarding who pharmacists are allowed to vaccinate and what vaccines can be given. Others not so much. But during the public health emergency, actually, HHS did an amendment, invoked the PrEP Act to allow pharmacists to give recommended vaccines down to age 3. So regardless of what the state rules are at the moment, pharmacists are allowed to administer all routinely recommended vaccines down to age 3. Now, it's not that I think many pharmacists want to vaccinate young kids, but it's right now, there's no prohibition in any state, regardless of what the state rules are, against doing this. there's lots of reasons for us to really want kids to get vaccinated in their medical home. Again, there's all the other important things that happen to well child visits. But HPV vaccine is a multi-dose series. It may be more convenient for families, especially for that second dose, to complete the series somewhere else. But pharmacists can do it. It's also true that there's actually not that much pharmacist vaccination, even for something like influenza vaccine, which I think is very widely given in pharmacies. So it's, even though it's allowed, it doesn't seem to happen all that much.
Great.
Understood. And sort of along the same lines with the pharmacy vaccinations, the question is, they've heard that some pharmacists, some insurance companies won't pay for pharmacies. And I would wonder if doesn't the federal ruling sort of somewhat mandate that insurance companies would pay for it if pharmacies give it?
That's a good question. I don't think the PrEP Act changed the fundamental structure of insurance benefits. So if vaccines are covered as a medical benefit and the pharmacy is not able to provide medical benefits under a private insurance plan, I think that still would be an issue in spite of the PrEP Act, although maybe someone can correct me. For children who participate in VFC, there are pharmacies that participate in the VFC program in some jurisdictions, but it's not very common. So there are limitations for VFC program eligibility in pharmacies.
Great. We had a number of comments about the pharmacy. I mean, what is your response? And this is Dr. Spinner. What is your response to parents that refuse or want to delay the HPV vaccine at each visit?
So, I mean, what our docs do is really, attempt to explain the advantages of giving it at that earlier age, or even traditionally at age 11 or 12, rather than waiting until they're 14, 15, 16, mainly because of the 2-dose versus the 3-dose series, and also for the fact that, we are preventing cancer. And the sooner we can prevent cancer, the better. There's no reason to delay that vaccine. And so but that is a challenge. We all know that. A lot of families have heard a lot of different things about the vaccine. And it's still a barrier that we have to overcome. But it's just a matter of really focusing on the cancer aspects of it. I think that's really changing a lot of the views, rather than talking about it as a sexually transmitted disease, which parents, of course, always assume that their child will never, have that opportunity until they're, 40 or 50, apparently, because that was the attitude they always had. But talking about it as a cancer vaccine, the earlier we give it, the better, is I think the way to go.
And that provider recommendation is so important. How the provider talks about the vaccine and makes it clear that this is a recommended vaccine, just like the other vaccines we recommend for kids, really makes a big difference.
Absolutely. And this is such a fantastic discussion. I want to say thank you so much to all our panelists. The questions have been flying into the chat, but unfortunately, Mission Control has informed us that in order to stay on time, we are going to need to wrap it up. But just to summarize, we learned so many exciting things. We learned that we're very far behind, but we can catch up. We've learned that a strong recommendation, simply saying your child is due for HPV vaccine today, is the most important thing you can do. If you start that at 9, you have more chances to get that child vaccinated on time. And that's been very effective for a lot of people. We're actually going to hear a lot about what people's experiences have been with starting HPV vaccination at age 9 tomorrow during one of our panel sessions. So if you are interested in that topic, please stay tuned for more. And now I'd like to just take the last minute to do another poll. So please pull out your phones for a second poll. In a short phrase, share with us what your big takeaway is from this conversation. Lots of great things here. Educate and vaccinate, start at 9, have hope, we can do it. Don't
Like
delay.
everyone's really positive here.
Yeah, I love the energy. It's fantastic. And people, please keep entering in the Slido comments as you go. I want to respect our time. So, because even in zero gravity, it's important to stretch our legs. So we're going to take a 8-minute break before the next panel, which will start at 2:10. We're going to take a break to before the panel, which is There's Space for Everyone, a panel on HPV vaccination in diverse communities. Be sure to get up, moonwalk to your nearest beverage, and meet us back here in 8 minutes at 2:10. If you make it back a little early, please take a moment to share your thoughts with us on social media, and be sure to use hashtag HPVRT21. Thank you so much to our wonderful panelists.
Thanks, everybody.
Thank you.
Hi, everybody. Welcome back. I don't know about you, but that music makes me both feel like I'm floating and ready to keep going. So fabulous job to the Roundtable for finding that Spotify music. NASA's Twitter motto is "There's space for everybody." We believe this applies to vaccination as well. Every child should be fully protected from vaccine-preventable diseases. There are significant racial and ethnic disparities in some HPV cancers. For instance, a higher incidence of cervical cancer among Hispanic and non-Hispanic Black women compared to non-Hispanic white women. HPV vaccination can help eliminate these disparities. Let's do another poll. Pull out those phones in the Slido. All right, based on 2019 NIS teen data, we know we're all anxiously awaiting the 2020 data. What population group has the highest rate of receiving at least one or more HPV vaccinations? Give everybody a little bit longer. Answers are still coming in. I'm going to do mine. All right. All right. And the votes are in. So we're going to show the correct answer. And the correct answer is actually Hispanic Latinx teens at 76.8% who have received one or more doses of HPV vaccine. On the next slide, you can see the rate range here. It ranges from 68% among white teens to 76.8% among Hispanic and Latinx teens. And if on the next slide, we look at HPV up-to-date rates by population group, we continue to see some variation. Here, Asian Americans and Hispanic or Latinx teens were the most likely to be up-to-date on vaccination rates compared to non-Hispanic white teens. And this is for ages 13 to 17 with the NIS teen data. A systematic review and meta-analysis from one of our upcoming speakers, Dr. William Callow, demonstrated that Black and Hispanic patients were less likely than whites to complete the full vaccine series after initiation, and that these differences are likely driven by differences in access and by differences in the care that's received based on someone's race and ethnicity. On our next panel, moderated by Dr. Sherry Wallington, will help us unpack this information and consider how the pandemic may have caused shifts. Dr. Wallington, the spaceship is yours.
I'm Dr. Sherry Flint Wallington, Assistant Professor of Health Disparities and Oncology at the George Washington University School of Public Health and School of Nursing. It is my delight to serve as the moderator for this panel presentation. The past year has called upon the consciousness of every citizen to recognize racial and ethnic disparities that are clear and large in our country. The HPV Roundtable has a firm commitment to advancing health equity, a field of study close and dear to my heart and scholarly pursuits. We will start this session with a short presentation by Dr. William Callow, who co-led a meta-analysis of HPV disparities. This will give us a context for considering pandemic impacts on HPV vaccination in diverse communities. We will then hear from 4 experts representing work in Asian American, African American, and Afro-Caribbean, American Indian and Alaskan Native, and Latinx communities. Now here's the best part. You will get to ask your questions of the panelists for a 25-minute moderated conversation. I already have a few questions in mind myself. We are going to learn a lot together, so let's get started.
Hi, my name is William Callow, and I'm pleased to present about our study, Disparities and Reverse Disparities in HPV Vaccination, a systematic review and meta-analysis. Every year, over 45,000 new cases of HPV-associated cancers are diagnosed among women and men in the United States. And we know large racial and ethnic disparities exist in some HPV cancers. For example, Black and Hispanic women had higher rates of HPV-associated cervical cancer than women of other races and non-Hispanic women. However, studies disagree about whether racial and ethnic groups have lower or higher HPV vaccination rates, an important issue given large disparities in some cancers. The objective of this systematic review and meta-analysis was to characterize and explain racial and ethnic differences in HPV vaccination. To do this, we searched 4 databases to identify studies published between January 2006 and July 2017. Our search strategy used a combination of terms related to HPV vaccine, uptake, and race ethnicity, with small variations as required by each database. Eligible studies were those that used data from a US sample to report HPV vaccination rates in males, females, or both, with at least one comparison between a racial or ethnic minority and white study participants. 2 reviewers independently extracted effect sizes describing the association between race and ethnicity with number 1, HPV vaccine initiation, defined as individuals with at least 1 dose out of all eligible individuals, and second, follow-through, defined as individual with all recommended doses among individuals with at least 1 dose. We use random effect meta-analysis to synthesize effect sizes for comparisons of whites or non-Hispanics to Black, Hispanics, Asians, or all minority groups combined. Of over 8,000 records, we identified 118 studies met inclusion criteria, and these studies reported vaccination data for almost 3.1 million adolescents and young adults. Overall, 41% of studies included a national sample and 41% used probability sample to identify participants. Response rate information was missing in 32% of these studies. 58% of studies used self-reported HPV vaccination data, with the remaining studies using clinic vaccination records, insurance claims, or data from an immunization registry. Overall, studies show no racial or any differences in HPV vaccine initiation. However, when restricted to studies using provider-verified vaccination data, minorities were 6.1% more likely than whites to initiate HPV vaccination, and disadvantages were larger for Hispanics. Self-reported data show the opposite, an overall disparity among all minority groups. On the other hand, minorities were 8.6% less likely than whites to follow through with the full HPV vaccine series, a disparity present for both Blacks and Hispanics, regardless vaccine data was self-reported or provider verified. In conclusion, high-quality studies, those using provider-verified data, found that racial and ethnic minorities are more likely to initiate, but less likely to follow through with HPV vaccination. The finding of higher HPV vaccine initiation among minorities is both promising and unique, and suggests potential reductions in HPV cancer disparities. Finally, I would like to highlight that the US is facing a significant vaccination gap, especially for adolescents. So we don't know yet how the pandemic has affected the vaccine uptake for diverse populations. We thank you for your time attending this panel, and I hope you read our full paper.
Hi everyone, my name is Milky Vu and I am at Emory University. So in this presentation, I hope to do 2 things. The first is to talk about a systematic review that we recently completed on determinants of HPV vaccination among Asian Americans. And then I want to talk about one of our projects that partly built on the results of this systematic review, but specifically looking at HPV vaccination among US Vietnamese. And for both projects, it used the P3 model, as you can see on the right side of the slide, as the guiding framework. And this is a model that assesses practice, provider, and patient level determinants of preventive behaviors, such as HPV vaccine acceptance and uptake. So to start with, this is a systematic review that we published in 2020. And the motivation behind this study was because we looked at data from several nationally representative surveys and found low HPV vaccine uptake among Asian adolescents and adults. And we were interested in understanding facilitators of and barriers to HPV vaccination in this population. Now, I believe this article is listed as a part of the pre-reading. So just for the sake of time, I'm going to summarize some of the key findings. So 26 articles were included in this review, and the ethnic groups most commonly studied include Koreans, Chinese, and Cambodians. And one thing that we note was the variability in terms of report vaccine intention, initiation, and completion prevalence. And this goes to show the heterogeneity in Asian communities and across studies, and also highlights the need for disaggregated data by Asian subgroups to understand possible disparities in health behaviors and outcomes. Now, we found that only 3 studies measure practice-level determinants of HPV vaccination. And practice-level determinants include the availability of multilingual services at the clinic, as well as insurance policy regarding reimbursement for HPV vaccination. And in addition, we've found 12 studies that measure provider-level determinants, and all of them assess the communication between providers and patients or parents. However, a shortcoming of the existing literature is that these studies have only assessed the presence or absence of patient-provider communication about the HPV vaccine, but none of them actually measure the content of the HPV vaccine recommendation or discussion. Now, at the patient level, and again here just for the sake of time, I'm presenting the determinants most commonly noted across studies. Now, those include vaccine knowledge, perceived safety or side effects, perceived susceptibility, beliefs about the relationship between vaccination and sexual activity, perceived costs, and motivation to get protection from disease. And these can be relevant targets for interventions or education programs to improve HPV vaccination coverage in Asian communities. So now I want to talk about a project we recently concluded that built on some of the findings from the systematic review. And we were motivated partly due to the fact that, as you can see in the review, very little research has looked at practice level measurements or assessed the content of providers' HPV vaccine recommendation. So we conduct a mixed method study with US Vietnamese parents and assess the P3 factors influencing their decision-making about HPV vaccination for their adolescent children. So just some preliminary findings from the surveys and interviews. We found a desire from parents to have clinic-based materials about the HPV vaccine in Vietnamese. And this is because parents know that even when they might be fluent in spoken English, parents will still encounter troubles with understanding medical terminology in English. And in addition, there is a need for reminder systems of HPV vaccine appointments, especially for those who had initiated but not complete the vaccine series. And in addition, we found that provider recommendation, especially a high quality recommendation that emphasized same-day vaccination or the cancer prevention values of the HPV vaccine, positively impact HPV vaccine intention and uptake. And parents who discuss trust in providers also more likely to accept vaccination. Now, for patient-level findings, one interesting result was that because of the way the HPV vaccine is often translated in Vietnamese, parents thought that it's only for cervical cancer prevention, and thus only females should get the vaccine. So altogether, these findings show the different barriers to HPV vaccination that should be addressed in future interventions at the healthcare practice, provider, and patient level for US Vietnamese in particular, but possibly also other Asian or immigrant populations for whom English is not a native language. So I would like to acknowledge the different funders that support this study. Thank you so much for attending this presentation, and do not hesitate to contact me with any questions. I'm happy to talk.
Hello, everyone. My name is Dr. Patricia Juden. I am a representative of the African Caribbean Cancer Consortium. I have no financial disclosures. So AC3 was established in 2006 and comprises of over 30 institutions across the globe. And our mission is to understand all of the factors affecting cancer outcomes in populations of African descent. And we want to use this information to help mitigate these disparities. As I mentioned, we are a global network across 16 countries in the Caribbean, 4 countries in Africa, and across 12 states from coast to coast. Our leadership is divided by site and country and comprises of researchers, cancer advocates, and oncologists. We're also divided into 3 committees, and our working group leaders are further divided into site-specific cancer groups. The Women Cancer Group focuses on breast cancer, cervical cancer, ovarian cancer, as well as other GYN-related cancers. And some of what we looked at is HPV in the African diaspora. And so in one study, we looked at HPV prevalence in the Caribbean versus in the United States, and found that women in Jamaica had the highest prevalence of HPV infections in comparison to women in Tobago and white women here in the United States. Next, we looked at the HPV genotype distribution and found that high-risk genotype most prevalent in the Caribbean population, that is Tobago and Jamaica, was HPV 45, whereas HPV 33 was most prevalent in the United States. And though not statistically significant, HPV 16 and 18 was most prevalent in the Caribbean as opposed to the United States. We also looked at the most common HPV subtypes by country, and this is both high-risk HPV genotypes and low-risk HPV genotypes across 6 different countries in the Caribbean and in Africa, and found that there was wide variation of the most common HPV subtypes in those regions. We then looked at the proportion of HPV infections covered by current non-valent vaccine by country and found that countries in Africa had the lowest coverage of high-risk HPV infection as opposed to those in the Caribbean. Also, there was very low coverage of low-risk HPV genotypes in the majority of locations. Other publications have looked at attitudes towards HPV in the Bahamas, and also the distinction between high-risk HPV genotypes in the Caribbean versus those in North America and in Europe. Also here in America, we've looked at the knowledge of HPV and the human papillomavirus vaccination between Black women and white women. And participants of African descent were less aware of HPV than whites, and also were less informed of the HPV vaccination, and that HPV was a causative agent of cervical cancer. And although the majority of women in this cohort had heard of the vaccine and had heard of HPV, the proportion of women who were Black who had heard of the vaccine were less than those who were white. Also, looking at vaccine acceptability among US-born and immigrant Hispanics and US-born and immigrant non-Hispanic Blacks, the overall acceptability of vaccination was low in all groups. Black and Latina immigrants were less likely to know where they could get vaccinated and reported more concerns of cost. US-born non-Hispanic Blacks were least likely to endorse HPV vaccine safety. Although many of our studies are conducted overseas, the importance and relevance to us here in America is that the Black immigrant population has increased significantly since the 1980s, with the majority of immigrants coming from the Caribbean and from Africa. Also, historically, all Black individuals generally were categorized as African Americans in research. However, there are unique and important differences among each ethnic group. And these key differences are in social behaviors, health practices, beliefs, as well as language proficiency, all of which affect health outcomes. So our goal is to continue our transdisciplinary research. We look at different health systems, we look at epidemiology, biological and behavioral research, and see how this information can affect interventions and also health policy changes that will ultimately increase cervical cancer screening and HPV vaccination in these populations to eradicate cervical cancer. Our future directions is to expand our collaboration across the globe, improve our collaboration for funding, and also continue advocacy and community engagement. Thank you for your attention today.
In the spirit of the theme of this meeting, I label my presentation as "We can reach new heights, as long as we outfit the shuttles based on the needs and wants of our passengers." The natural history of cervical cancer gave us two powerful tools to eliminate cervical cancer as a public health problem in the world: HPV vaccination and HPV testing. And we have worked a lot in those two fronts. But today, I want to share with you our trial to promote HPV vaccination among daughters of Latina immigrants in Alabama. Our goal was to promote HPV vaccination, and we spend a lot of time in the formative assessments. As you can see, we're focusing on girls because when we started this work, the vaccine was only recommended for girls, and then we couldn't then build the intervention for boys because our formative assessments were done for girls. But also, when we're doing the formative assessments, the community told us that they were very concerned about healthy eating in the community, adapting to the new eating habits in the new country. So since we need a control group, we developed another intervention to promote healthy eating and nutrition label interpretation as a control group. And it turns out that both interventions were efficacious, and I cite the publications here. The primary outcomes was completion of first dose and completion of all 3 recommended doses at the time. The PAN3 and the health belief model have guided our work throughout, where we map all the constructs and the intervention strategies. And also we use the community health worker model, where we train community health workers to deliver the intervention in the community where the moms and daughters are. Because Latina immigrants here in Alabama are very isolated, they don't drive, and they're monolingual. We did the sessions where they live. So the clusters were the apartment complex or the trailers where we form groups of women. Sometimes we met in somebody's house, or we have a tent with chairs that we met outside. And the intervention consisted of 4 group sessions and 1 individual session. And as you can see, we focus a lot on the culture, but also intertwine knowledge as well as skills that were needed for them to vaccinate their daughters, like communication skills, as well as problem-solving skills. The individual session that you see here is where we then narrow down to that particular woman to understand the barriers and facilitators and really assure self-efficacy that she would vaccinate her daughter. And the last session was more festive, talking about communication between mothers and daughters. This is the consort diagram. I just want to call attention to our retention. That was over 90% in both groups, and that our analysis, what we use intention to treat. This is our results. As a behavioral scientist, I never had an intervention that powerful. As you can see, women in the intervention group were almost 16 times more likely to vaccinate their daughters than women in the control group. That means completion of the 3 doses, which has been amazing. In conclusion, we have shown that a community engaged, theory-driven, culturally relevant intervention can effectively promote vaccination among daughters of Latina immigrants in an emerging Latinx state. It takes a village. I have a wonderful group of individuals that I work with, staff and investigators, and our study was funded by the National Institute of Minority Health and Health Disparities. Thank you.
Hello, everyone. Thanks so much for having me today. My name is Adolescent, and I'm going to be talking a little bit about HPV vaccination in Indian country. I have no financial disclosures, but a little bit more about myself. So I'm a citizen of the Confederated Tribes of Grand Ronde, which is located here in Oregon. I'm a general pediatrician, and I practice both at Oregon Health and Science University and at Grand Ronde Health and Wellness Clinic, which is my own tribal community. My tribal clinic is located in the Portland area of Indian Health Service, or IHS. And as a reminder, IHS supplies healthcare. It's one of the few federal healthcare systems that we have based on treaties that were signed by our ancestors. This is a zoom in of the Portland area, and there are 43 tribes across Oregon, Washington, and Idaho. The purple is pointing to where I live in Portland, Oregon, as well as my tribal site, which is Grand Ronde. And we are super lucky that in Portland, we are also served by the Northwest Portland Area Indian Health Board. This is one of the epicenters. It's one of 12 national centers, and they're charged with collecting tribal health status data, evaluating data monitoring and delivery systems, and super important, assisting tribes in identifying local priorities for healthcare delivery and health education. And so I partner with the board on one of these projects that was identified by local tribes, and that's the Northwest Tribal Cancer Coalition. So what is a pediatrician doing partnering with a cancer coalition? Well, as we all know, HPV vaccination is primary prevention for HPV-related cancers. And so I'm able to attend some of the Cancer Coalition meetings and give talks about vaccinations as my expertise in giving vaccinations in children, as well as my own lived experience as a Native American physician practicing in my own tribal community. So what do we know about HPV vaccination in tribal communities? So what we know is that American Indian Alaska Native women die at almost twice the rate of non-Hispanic white women who have cervical cancer. We also know we generally have higher vaccination rates in the general population, including HPV, but there are still challenges in HPV vaccination. Initiation is greater than completion rates. So the first dose, we're great at giving that, but not completing, and barriers still exist. This is some data which was collected in July of 2020 by the board, and this is looking at the 10 tribal sites here in Oregon serving Native Americans, and in the blue bar, it's looking at the first dose of HPV vaccine, and the purple is looking at the completed series. So as you can see in all 10 sites, we're doing pretty well in that first vaccine, but having a lot of trouble with the completion rate. So what do we talk about during these Cancer Coalition meetings? So we talk a little bit about framing the conversation. So like with any vaccination, make a strong recommendation as that provider, the same way, the same day. And so we bundle it together with Tdap and then the meningococcal vaccine, and really reframing how we talk about the vaccine as being cancer prevention. And it's also super important to make that strong recommendation, but also acknowledge that there may be different cultural values. And so this was a study that was done in June of 2013, where they met with 4 different focus groups, including adolescents, parents, young adults, and health professionals. And what they found is really actually pretty similar to what we found when we did a focus group at the Northwest Tribal Comprehensive Cancer Coalition, surrounding knowledge, education, the mistrust of the medical system, which is also mistrust of the federal government, and then also remembering our past of women being forced to be sterilized. Some common concerns that I often hear in my clinical practice actually match up really well to what we learned during those from that study and also from our focus group. And so addressing each one of these when you have a parent or a guardian who has some hesitancy to the HPV vaccination. Lastly, what I really like about these Cancer Coalition meetings is that they include not only providers, but often the whole office staff or clinical staff at the tribes and the immunization coordinators and just community members as well. And so really it's a whole, not just office, but a whole community approach. And these are some of the things that we talk about, as well as to making sure that we're completing those series for our teens and adolescents. Thank you so much for having me today.
Okay, thank you so much for joining us. These were great presentations. I want to again thank Dr. Kahlo, Dr. Vu, Dr. Judean, Dr. Scaracini, and Dr. Impey. So we're going to have fun today. We're just going to dive right into it. And if I can just make sure all the panelists have their cameras turned on, okay? And then I want to start with a question that I have after listening to all of your presentations and the great information. I want you to think for a moment, how can we take the information that you have shared today and translate it into actionable solutions to increase, or shall I say, to go boldly where no one has gone before in terms of increasing HPV vaccination, particularly in diverse communities? So if you briefly could cover that question, that would be great. So we'll start with Dr. Kahlo.
Thank you so much. Can you hear me?
Yes.
Perfect. Before answering that, I have a question in the Q&A section about, there's a confusion about what I reported about not seeing differences by racial ethnic groups, and then I reported that Hispanics were more likely to initiate vaccination. That results were because when we segregated data based on the self-reported versus provider verified, that's when we observe that differences. But when we combine all data together, we observe no difference. I want to make that clarification, because that was a question that was not unanswered. So based on your question, Cherry, I think for some of these minority groups, it's really important to really go to the places that these people work, live. We have a very interesting discussion a moment ago about why not expanding the HPV vaccination services in pharmacies. I think there's a potential place that we can explore. In addition, we need to do a better job in terms of adapting our information to be more culturally appropriate. You know, there's a lot of information overload and misinformation for some groups, like for example, Hispanics or Blacks. It's really important to tailor that information, not only about the wording, but also about the images that they're saying. You know, role modeling is so important. You know, the role of clinicians also sharing that information. So that's my response.
Yes, thank you, Dr. Kahlo. Dr. Vu?
Sure. So I think that from my research, there's a couple of points, and I agree with Dr. Kahlo about the point with, culturally appropriate interventions. I think particularly with several group of Asian patients, but perhaps for other immigrant patients as well, in addition to understanding their cultural beliefs, I think that having linguistically appropriate resources are very important. So for example, in my research with US Vietnamese, there are parents that say that, like, I am fluent in spoken English, but it doesn't mean that I understand all the medical terminology in English. So for example, if I go to a clinic and they hand me, some information about the HPV vaccine, it will be hard for me to understand or make a decision about the vaccine on the spot. So I think making sure that, clinics and, outside the other venues, patients are able to access information about the HPV vaccine in their own language, so that it can facilitate understanding and ultimately HPV vaccine acceptance and uptake.
Thank you. Go ahead, Dr. Oh,
Sorry.
no, continue.
Okay. I think another point, especially for Asian populations, is that too often we use the umbrella term Asians, but really Asian Americans. This is a term that, can be used for populations coming from, over 30 countries, speaking more than 100 different language and dialects. So efforts to collect data that are disaggregated by subgroups, both in terms of cancer incidence rates as well as HPV vaccine uptake, is important and needed for us to understand where possible disparities exist, and for us to be able to target and address these disparities.
Thank you so much. Dr. Impey.
Good afternoon or morning, depending on where you're at. So I think for me, it was really, I think many people mentioned that cultural perspective, but also the historical perspective as well. And something else that we learned too is just maybe a lack of knowledge or education surrounding that. And so in my personal clinical practice, when they are turning 8 years old, letting families know next year your son or daughter is due for their HPV, which is a cancer preventing vaccination. And please let me know if you have any questions. So starting that, the conversation and allowing time for parents and guardians to ask any questions that they may have early and often.
Oh, great. And Dr. Scaracini.
Okay, so for us, so this was a pragmatic trial that was developed in collaboration with the community. Like the other speakers, the Latinx population is also very heterogeneous. And sometimes it's not only the country of origin, but where they are. So Latinx, even though you may be from Mexico or Costa Rica, but in Alabama, the environment may be very different. So for us, I think because we develop with the community, the next level is really do it. We know how it works. It's mobilize, those community health workers and continue to promote the vaccine in a way that is relevant to this population. Also, and this is very relevant in the Latinx community, but also other communities, it's not so much the information in their language, but who gives the information. Because that's where, in our case here, working with Latinx is more important than the piece of information is who gives that piece of information and say this is important. So we work a lot with the trusted community members to be our messengers.
Oh, great. Thank you so much. Dr. Judin?
I think with the information that I presented, it's important to understand the limitations of the different subgroups and the different subpopulations and their perceived barriers to HPV vaccination. Because I think that's going to help and translate into the counseling piece when you see the patient in front of you, understanding what their fears are and the differences between the two. For example, with African-American communities, they tend to be more fearful of the side effects and the safety of efficacy of the vaccine, where for the Caribbean population, it may just be more of just a lack of information. And so once they have that information, they're able to make the decision to get vaccinated. And I think Dr. Impey it was who mentioned the historical piece, which is, I think, important for the African-American community and understanding the relationship over years and that they've had with medicine and medical communities and with experimentation, and bridging that gap when having these discussions about HPV vaccination, what it is and what it is not. And then lastly, I think it's also important to stress the likelihood that that their child or that the patient in front of you will get HPV in the future, and it's very high. And so I think sometimes patients don't really understand or grasp that.
Great, thank you so much. Now I'm gonna transition to, we've gotten several questions in the chat. The first question is, any thoughts about why oropharyngeal cancer rates are rising in white men, but are falling for Black men? Anyone want to take that? If not, I can address that.
Go for it.
Okay.
I know cervical cancer.
Okay, so part of what some of the research shows that it speaks to the differences and sexual behavior between groups, and then also smoking rates. And so that's where some of the research is focusing on those areas in terms of these differences we see in these declining rates. So another question is for Dr. Impey. The questions is there, I'm very interested in, I'm very impressed with the high vaccination rates among Native Americans. Can you speak to these differences? Do you think there are cultural issues at play that result in higher rates, or more about your efforts?
Thanks so much for that question. I think that's an interesting question. In IHS, there are higher childhood vaccination rates. And I know that's something that many of the clinics really focus on in terms of their outcomes. And then I would also say, I think the education that's been happening around HPV cervical cancers in American Indian Alaska Native women being twice as high. And so really that focus on the primary prevention and educating families, I think has made a difference. But I think it's probably a combination of all of those things. And really the fact that this cancer coalition that I work with is coming from the tribe, so the community themselves, too, who are working really hard to do education and knowledge on this to get out to the communities themselves.
Okay, great. And another question is, are you seeing variations in HPV vaccinations when you account for social economic factors? So are you seeing variations in HPV vaccinations when you account for social economic factors? Anyone want to take that?
I would like to say that in our systematic review and meta-analysis, we did not have the chance to analyze any of those socioeconomic variables. So from our study, we cannot respond to that question.
And I would add too that many health organizations, especially the federally qualified health centers, are really moving forward with capturing the social determinants of health in the electronic health record. And I think that would help to address some of these social determinants issues as well as economic factors. So I think that we could expect to see more in the literature regarding that. Here's another, oh, go ahead.
Sorry, I was just going to answer that question. There are some studies that do control for socioeconomic factors, and there's still a difference. I think there was one from Michigan where they looked at completion rates of vaccination, and there was still a difference.
Oh, great. Here's another question from Tammy. I'm wondering about the value of text reminders in various languages to help for dose 2. I had great results in a pilot project with text reminders in English and Spanish, and I'll open that up to the panelists, but we've seen a lot of research and interventions using text reminders to parents and adolescents, some to adolescents only in different languages. So any comments about that?
Yeah, so like I mentioned, so we did pilot qualitative interviews with US Vietnamese parents, and one of the things that came out of the interview were that a lot of parents who had completed the first dose of the vaccine for their children actually did not know that they needed a second dose or third dose possibly, and it could be, you know, that their providers didn't communicate it to them, or it could be that it was communicated but it got lost somewhere or they forgot about it. So I think definitely that text reminder is something that could help facilitate series completion. We have not done an intervention obviously on this, so I can't speak to, you know, the value whether having it in language or not would be helpful, but I imagine it would be, for especially for patients or parents for whom English is, you know, they have limited English proficiency.
Okay, great, thank you. Is there literature available to assist providers with understanding that all Blacks should not be classified as US Black, especially when you have ethnicities among Blacks?
I think there are there aren't any studies specifically to say that, but there are studies that are looking at, that are separating the two. So they'll separate US Blacks and Caribbean, and they'll specify where exactly the Caribbean population or African, and maybe highlight that in the discussion. But as far as studies to specifically say that we should be, separating the two, I have not come across that.
Right, and I was gonna agree with you, nothing to that, but I think it's important to look at differences between subpopulations. And so that brings me to another question. Can each of you talk more about differences between subgroups of Black, Asian and Hispanic, Latinx, and Native Americans, and how these subgroup differences relate to vaccine attitudes?
I'll start, but it's more, I think Rebecca Perkins actually can answer that. She published a paper on where they look at some subgroups of Latinx, and language was more important. Actually, parents that spoke Spanish were more likely to vaccinate because a lot of the immigrants, vaccine is so much in the forefront in Latin America that a lot of times we see that Spanish-speaking parents are much more willing to vaccinate than Spanish-speaking, but it's more also has to do with acculturation. But there was, I don't remember, Rebecca, in the paper you published not last year on those differences. And but they didn't, in Latinx, they didn't find a lot of differences across, minor differences across the subgroups.
Dr. Judin, Dr. Vu, Dr. Impey, any remarks regarding that?
Yeah, I think one thing that I would add is, like in addition to cultural differences, one thing to think about just the different circumstance or historical context in which, certain subgroups, for example, immigrate to the US. So again, going back to my work with US Vietnamese, one thing that we notice is that a lot of parents are recent immigrants. And so, like they've spent a lot of time in the country of Vietnam. And we can have a different conversation about global vaccine inequity, but in Vietnam, for example, the access to HPV vaccine is very limited. And there's a lot of parents actually prior to immigrating did not know about the vaccine. And there's like their first knowledge of the vaccine and the need to vaccinate their adolescents is when they came to the US and had interactions with US healthcare system. So that lack of knowledge, due to the context of the country that they came from, I think should also be taken into account.
Oh, thank you so much, Dr. Vu. We're going to transition to another question that asks about resources. Is there one place, website perhaps, that we can go to summarize culturally sensitive ways to recommend the HPV vaccine to various racial and ethnic groups? And I know there are many organizations, HPV advocacy groups. The CDC has great communication pieces that speak to different diverse groups, but from your own experiences, what resources are you aware of that speak to that?
Usually, and again, I'm a little reluctant to give a blanket.
Yes.
When I train our residents, I say it's about common sense and not stereotype, because a lot of times that's the risk. When we work with racial and ethnic minorities, there is a risk of stereotyping and thinking that all Latinx are the same.
Yes.
So I try to emphasize, listen to what they're, and then you can adapt your strategies, because the more we move in these diverse communities, I think that we have a major risk here of stereotyping. So I advise just listen to see what they are telling you. If it's a community intervention, or if it's an individual patient, or if it's an organization, have a feel for it, and then tailor and pilot test and pre-test your messages. And I think that's more helpful than saying, this is how you should do it for this specific population.
Oh, great, Dr. And Scarcini, I'll add that there isn't a one size fits all strategy, and we need to, move away from that. And I think this is where we see the value of community engaged research as it relates to HPV vaccination uptake, because you're involving the community, the target population, and they really can tell you what works and what doesn't work, don't they? So I think that that's where we could see the value. And many health organizations are putting together patient panels, community advisory boards, and I see the great value in helping to frame and develop strategies for uptake. Okay, so we're gonna keep moving right along. The questions keep coming in. I did say we were gonna have fun today, right? Okay, so another question is there any work being done in juvenile detention centers, the incarcerated population where access to care could be more difficult as it relates to HPV vaccination uptake? Anybody aware of any work being done in juvenile detention centers?
Not aware of any.
Yeah, nothing that comes to mind. I think certainly that's definitely a gap. Let's see. Okay, here's another question. This is Eric. I've seen several meta-analyses show that text reminders are one of the most effective ways of increasing HPV vaccination uptake. And I smile at that because, some funding organizations, even though that's true, they don't necessarily consider that very innovative now. But I do think it's still one strategy combined with other strategies that might be successful in improving vaccination uptake. And then leveraging, again, the electronic health record, those are also some strategies. So any comments about text message reminders?
I think that's a great example of a way that we can reach our parents and guardians. I think there was another question asking also about would these texts go to the teens, and I think it depends really on who is listed, and then it would also, I think, depend on the state, as well as how old you have to be to consent to vaccinations. Here in Oregon, it's 15 years and older versus in other states it may be different. But one thing I would say about the texting is I think it's a great idea, but some of my families I know sometimes struggle to pay their phone bill. And so just keeping that in mind, that we may be missing some families in different service areas or who don't have the financial means.
Oh, Dr. Impey, you said something so important. When you look at the data and cell phone penetration, we know that minorities have not experienced the same digital divide with cell phones as they have with computers, but there is a phenomenon that's referred to as intermittent access. Sometimes the phones may be on, sometimes the phone may not be on. And so that's an issue that needs to be addressed in developing text messaging interventions. How would you address that potential pitfall? So thank you for making that comment. And certainly we found that out in the District of Columbia when the schools transitioned to students working online from home, that we did see that digital divide in terms of cell phone and computer access and internet access. So that's something to keep in mind. Okay.
I want to mention there that for many Hispanic immigrants, they use prepaid phones.
Yeah.
And sometimes they have some disruptions in the coverage. Sometimes they have to, they are able to refill the phone. So that's another consideration.
Oh, great. And we're getting several comments about how successful text messaging interventions have been with Hispanic and Latinx communities, and then also comments about information related to Black women has been limited, but not, that comment doesn't specifically address in terms of what domain. Okay, so there was an earlier question related to, I was looking for Heather Brandt's question. Okay.
She said, how can we effectively address intersectionality among populations? Is it much more complex than only race and ethnicity? I'm especially thinking about public-private insurance status and geography place. How can we account, there's a lot of questions. How can we account for the rich diversity of people with whom we are working to increase HPV vaccination?
Oh, great. Thank you so much. So I saw Dr. Kahlo, you were shaking your head. So you want to take a stab at one or part of that question. There's a lot to unpack in there for sure, but I think it's an important thing to discuss.
Yeah, absolutely. I was shaking the head because I agree with some of the questions. Yeah, I think there's a very important issue about not only understanding race ethnicity, but at the same time, understanding that geography connection, is about access. And another issue that I have been thinking when we were talking about stereotyping, I think it's really important that we try to do a better job telling providers about the importance of recognizing culture and cultural preferences in terms of language and role modeling, and not confuse that with implicit bias, that we're not telling providers or practitioners that we want to do a better job with some populations because they have higher risk. I think we have to emphasize the message that is cancer prevention for everyone and not get confused with those concepts.
Oh, excellent. And then one question at the end, Dr. Brandt asked is, how can we account for the rich diversity of people with whom we are working to increase HPV vaccination? And I will say this again, I think this effort to really address and capture the social determinants of health, so that, as Dr. Scaracini said, we're listening, we're recognizing that when people present, they have a whole host of things that perhaps they've had to go through before they even get to the clinic, and acknowledging that also. And then one important social determinant of health is health literacy. And I think that speaks to what many of you have talked about in terms of culture, but also health literacy and how we help to frame the message and the communication. And I think not just focusing on the provider determinants, but also focusing on the social determinants of health that might impact HPV vaccination as well. Okay.
And can I make a comment? A lot of times too, I struggle with that too, because if you work a lot in screening, and when we see disparities in cervical cancer screening, it's not the same as HPV vaccination. As you can see, whites have the lowest uptake. So a lot of times I think in public health, we tend to go, there are many ways we can do it. Are we going for understanding that environment and going for the ones where there is the lowest uptake? In this case, maybe, that white population, and or then do the multi-pronged approach of having general messages that fit, and then target efforts, because that's what disparities is about, is because they need there are in need of targeted efforts that they, the big brush is not reaching them. So I think it's a struggle. And I think that is where we're struggling with the vaccination as well, is to say, where are we going to put our efforts?
Exactly.
But if it's disparities, then it's targeted. If it's everybody, then we need to find the common ground. And I think it's hard from a resource perspective.
Exactly. So
I agree. I was just going to add one more comment. I think it's important. I think it's important to understand where different communities get their source of information and what they find reliable. So, for example, I grew up in a Haitian household, and so generally Haitians tend to, if they want health information, they want it from the doctor. The doctor tells them what to do. They believe it, they'll take it, and they'll go. Whereas in an African-American community, they'll question more. And so I think it's important to understand where different subpopulations get their information. And what they find most reliable and use those sources in terms of promoting vaccination.
And Dr. Juden, in a lot of our work in the District of Columbia, we specifically ask populations, what are their preferred channels of communication? And it's not always the internet, it's not always Twitter or Facebook. And even in this social media age, we can't forget about traditional media still works. The newspaper, the radio. We've gotten great feedback from our Hispanic Latinx communities about getting health information from the radio. And so when we push social media, we also need not forget that traditional media and traditional formats, they still do work. Okay, here's a question. There seems to be some confusion in pediatrics. Who should engage parents about HPV? The doctor, the RN, or nurse assistant? Any thoughts on that?
As a pediatrician, I think it's a whole office approach or a whole community approach, really. And so in my personal practice, when my medical assistant is rooming a patient, she'll say, your child is due for some vaccinations today, and your doctor will talk to you further about that. So she like upfront lets them know. And ahead of time for each and every visit that we have, we print out their vaccinations that they're due for, even if they're coming in for a common cold, so that we're capturing them at every visit. And then when they get the first dose of the HPV vaccine, making a plan for that second one as well, whether it be we'll capture you at your next well child, or we'll make an appointment for you in 6 months from now. And so really, I think it's everyone.
Oh, okay. And what have been some of your experiences? A question in the chat related to both COVID and HPV vaccination in terms of education. What have been some of your strategies?
So some of my strategies have been discussing the efficacy of the vaccination, of HPV vaccination, how long it's been there, the studies that are coming from Europe and Australia about its efficacy, its safety, and addressing addressing each individual's concern about the vaccine separately. That's how I approach it.
Mm-hmm. Okay, great. And we asked earlier a question about juvenile detention centers, and I want to thank Emma McVeigh for her comment. She says, juvenile detention question. King County Public Health in Washington State does have HPV vaccine and sexual health education in juvenile detention, and partners with detention medical staff to provide the vaccine. So really, wow, that's a great outreach, and seems like a great partnership. And there again, the value of partnerships in helping to increase HPV vaccination is just so important. Okay. Oh, here's a question. Have you noticed a lack of vaccination or lower number of vaccination within the LGBTQ communities? Anyone want to comment on that?
I don't know the numbers per se, but I mean, as far as my experience with patients who identify as LGBTQ, I have had no issues with getting them vaccinated in terms of, I see women, so they're catching up with their vaccine schedules, but I haven't had an issue.
Oh, great. Okay. We're coming up around 2 minutes, and we still are getting questions in the chat, but just really some great comments about using TikTok and Instagram to reach some of the younger audience. Those are some new innovative strategies. But as we wrap up, I just want to remind persons in our audience, if we didn't get to your question today, there'll be a resource where these questions will be answered and followed up. But I just want to give all of our panelists a one moment to just say take a few minutes to comment on anything you didn't get to say or any strategies or advice, how our audience can act on this information, like taking this information that you have shared today back to their specific organizations, how they could, what are some tangible strategies they could implement in their organizations when they leave this session today. So I'll start with Dr. Carlo.
One thing, and connected to your last question about COVID-19 vaccination and HPV vaccination, I would like to say that it's a really important time to emphasize the importance of science and public health. That now that some of these parties are going to be making vaccination for adolescents for both vaccines, it's really important to tell how safe and efficient are those two vaccines and over adolescent vaccines. So I think it's a really good time for us public health scientists to spread that message about trust in science and medicine and public health.
Okay, really quickly, I think we're almost near our time. Dr. Juden, any final words?
I think someone actually emphasized it earlier, but just listening to the patient, listening to their concerns and answering them.
Okay, Dr. Impey?
Thanks. I think for me, it would be really getting to know the community that you serve. There are over 500 federally recognized tribes that are their own sovereign nation who have their own unique histories. And so really understanding the community.
Okay, Dr. Vu?
So for me, again, it's just the need to collect disaggregated data just to understand possible disparities in vaccine uptake across groups. And then one thing that came out of our study is just patients who place trust in providers are more likely to accept the vaccine when providers recommend it. So just thinking about that relationship between patient and provider and how trust can be actually a mean to increase vaccine coverage.
Okay, Dr. Scaracini, you get the next.
Okay, so my message is personal. Being a polio survivor, I know the consequences of not being vaccinated. And that's why we need to do everything we can beyond science with our neighbors, with everybody to get those kids vaccinated. Thank you.
I want to thank all of you today. It was my pleasure to serve as the moderator for this session. You all get an A++. And now I'll turn it back over to our MCs. And certainly I want to thank all of our audience participants. You've been great. Thank you.
Thank you so much, Dr. Wallington, and all of the fantastic panelists. This was exceeded our wildest expectations, as always. This knowledge will help all of us better consider how we advance health equity in our communities. And I think the messages of treating everyone with respect at every interaction to build the trust necessary so the patients can act on strong recommendations and advice from all of the community members, getting the whole office on board, all of those things so we can achieve on-time adolescent vaccination when it's most effective are critical. And talking to patients with trust and in their own language and at a level that everyone can understand is so critical. If you want to learn more, we encourage you to check out the suggested readings for each panel posted on our website. At this point, we'd like to do a check-in to see what you're thinking. On this poll, we want to know what you think you might do with the information you heard from this panel. Tell us which option you're most likely to take. Do you need time to contemplate? Was it generally informative? Will you share the information with your team or leadership? Can you apply the information immediately to your organization strategies? Ooh, everyone's gotten much better at Slido. This is very exciting. We can see the poll sliding up and down and people answering lots of questions. Wonderful. Okay, and as we let the poll sort of run down, fewer people are contemplating and more people are taking action, which is terrific. They say that this panel will inform their activities. Some people will be able to immediately apply it to the organizational strategies, and others will be able to take it back to their team or leadership. So that is fantastic. And I will now turn it over to Kristen.
Thank you. I am here. I had to turn the video off for some internet issues. It's been said that a dream is just a goal without a plan. We believe your organization can help make our immunization and cancer prevention dreams come true. Following this event, we're going to be convening our members to talk about what this information means for their organization and for us as a coalition. We ask you to do the same within your own home organization. In fact, we have 4 asks of you today. 1, share the information you heard within your organization. You can post takeaways on social media, share journal links and presentations and staff newsletters. Help us to get the word out on the urgency of catching up on childhood and adolescent immunization. 2, read up on the work of today's presenters and follow them on social channels or on LinkedIn. 3, if you have a leadership role, convene the team members to assess what this information means for your work. If you're in a clinical system, find out if your current adolescent rates reflect national trends. If you're a public health leader, consider how you're serving all communities to get vaccinated and how you can make vaccination more accessible. And finally, come back tomorrow, where you'll be able to hear about the work being done to look at geographic disparities and how immunization data can build smart strategies. Learn about best practices for recommending vaccination at age 9. I know Rebecca feels very excited about this panel. Lessons learned from health systems in an HPV learning collaborative during the pandemic. Just a reminder, you do have to register separately for today's session and tomorrow's session. So there's certainly still time to register, but if you haven't registered for tomorrow's session, please go ahead and do so. Rebecca, I feel like we need another poll.
Absolutely. We would like to ask you 2 more questions. We want to capture reactions to today's content. What one word best captures your reaction to today's plenary presentations? I think speechless is the first word. Great. People think they're really informative, inspired, fantastic, engaging, appropriate, respectful, comprehensive, amazing, excellent, timely, great. I love being able to read out this feedback to our fantastic panelists, and thank you so much. Amazing, passionate, relevant. People are ready to move, they're eye-opening, thought-provoking. Goals are attainable. That is always fantastic as well.
That is very encouraging, and we think so too. All right, we are going to have one final polling question for everybody for this public session. We want to challenge you to begin the true work after this event. So based on what you heard today, what actions can you take now to help get adolescent vaccination back on track? Go ahead and check all that apply. This is a reminder that all of this work and getting this back on track isn't going to happen without our action. We need to think about specific things that we can all do and what we can take away with and gather sort of all this energy that we've gotten from outer space and from the panelists. I'm not as good at these analogies. I got to work on that. All right, a lot of people are going to communicate and share the info. Actually, we've got a lot around all of these strategies: enhancing collaboration with partners, utilizing specific resources, improving community outreach. And what we really heard about in the last panel is community means lots of different things, right? And none of these groups are one specific community. So I think delving specifically into that, looking at our own data, right? We don't know how to improve if we don't know where we are, educating and training staff and bringing this all back. Fantastic. I'm really excited to hear the outputs from all of this excitement and what people are planning to do. Rebecca, I'm going to hand it over to you to wrap up.
Thank you, Kristen, and thank you everyone for joining us today. I hope you enjoyed it as much as we did. We will start tomorrow with another public session, June 10th at 12 p.m. Eastern. If you are a Roundtable officially designated member, you are still on the mission with us. We have an additional spacewalk for today. You have a little break, but we do need you back. We will reconvene in 20 minutes for a members only solutioning forum, because as Melinda Wharton shared, there are no elves. It is up to us to do the important work to get this done. And then we can see, we actually already are seeing, so exciting in the world of cervical cancer prevention, my favorite as a gynecologist, we're seeing the infection rates drop, the precancer rates drop, and then actually the cervical cancer rates drop in women under 30, which is just a spectacular outcome of everyone's hard work. So we'll see you in 20 minutes. This is Mission Control signing off for today. of you in the public forum tomorrow, and we'll see those of you who are HPV Roundtable members very soon in 20 minutes. Thank you so much.